This is the story about CR. CR is a right-handed 30-year-old man, and he is currently married and has a 5-year-old son. CR loves to ride his motorcycle. As a job, he is working as a car mechanic and as a carpenter. CR was involved in a motorcycle accident 2 months ago. From the accident, he sustained an unstable C5 vertebral fracture and a complete C7 spinal cord injury causing tetraplegia. What is C7 tetraplegia condition? It is a type of spinal cord injury, and it results from the damage to the spinal cord at the level of the C7 vertebrae. C7 tetraplegia typically results from traumatic events including car accidents, falls from heights, or sports-related injuries. This condition leads to varying degrees of paralysis in the upper and lower extremities. This type of injury disrupts the normal transmission of signals between the brain and the body below the level of the spinal cord injury. It affects the arms, hands, trunks, and legs. The extent of paralysis can vary from person to person and situation. Individuals with C7 tetraplegia face challenges with mobility and daily activities, and rehabilitation and therapy are crucial for managing and improving function and quality of life. With a complete spinal cord injury, specifically C7 tetraplegia, there are general features that are common across the board with patients. The first feature is a complete loss of movement and sensation in the legs and trunk, a bowel and bladder dysfunction, spasticity, which is exaggerated reflexes and muscle spasm. There's pain, numbness, or tingling. A patient can discover difficulty breathing and coughing. There's limited or absent sensations to the body parts where the tetraplegia is affecting. And it's important to note that a person with a complete C7 spinal cord injury, specifically tetraplegia, does not have the ability to move their legs or trunk, but they can move part of their shoulders, elbows, wrists, and they do have limited use of their fingers. Much like the general features of tetraplegia, there are also specific features that CR experiences. These specific clinical features CR experiences are difficult, shallow breathing patterns, which relates to the general feature of difficulty breathing and coughing. Like we noted in the last slide about general features, how a person with complete C7 spinal cord injury, tetraplegia, do not have the ability to move their legs or trunk, but they can move their shoulders, elbows, wrists, and have limited use of fingers. CR has full active range of motion in his C-spine and bilateral shoulders. He has bilateral dorsiflexion and is limited at a neutral, and his finger flexors are at 50% range of motion, which relates back to the limited use of fingers. CR experiences exaggerated clonus with bilateral plantar flexion, which relates to the general feature of exaggerated reflexes or muscle spasms. CR shows dermatomes in C1 to C7. CR shows myotomes from C1 to C6 with a score of 4 out of 5, and myotome C7 is a score 3 out of 5, which relates to the general feature of pain, numbness, or tingling. Since being in the spinal cord unit, CR has had 2 episodes of autonomic dysreflexia, which relates to the general feature of, again, pain, numbness, or tingling. CR does need max assist with 2 people for transfers of supine to long sitting, as well as sliding board transfer from bed to wheelchair due to the complete loss of movement in his legs or trunk, and this can be related back to the general feature of limited or absent sensation in the body. CR is not ambulatory, and he does require assistance with his wheelchair proposition. This relates back to the general feature of a complete loss of movement in legs and trunk. And lastly, CR will need to use a Foley catheter to use the bathroom, and he will need to have specific bowel routine days, and this relates back to the general feature of bowel and bladder dysfunction. There are 3 activity limitations that CR will suffer from. The first activity limitation is that CR experiences less social interaction since the accident and being diagnosed with his injury. The second activity limitation is now that CR is in a wheelchair, he is unable to ambulate and he has lost both motor and sensory control of his trunk and his legs. And the third limitation is that CR is now incapable of using his legs and trunk to help support himself. Much like activity limitations, there is participation restrictions that go hand in hand with each other. The first participation restriction is that CR will have difficult social interactions with his wife, son, friends, family, and coworkers due to his shallow breathing and minimal facial interactions, which makes it hard to talk and interact with other individuals. He also appears to be angry and frustrated with the people around him and not cooperating with suggestions on how to adapt with his new injury. The second participation restriction is mobility limitations. Because of CR's C7 Tetraplegia, he can no longer ride his motorcycle, which was one of his favorite activities. He has lost complete feeling and voluntary use of his trunk and legs, which means he will be in a wheelchair for the rest of his life. The third participation restriction is that CR cannot individually engage in self-care activities. He needs maximal assistance with eating, grooming, dressing, personal hygiene, and toileting. He will also need to use a catheter to go to the bathroom. In this part, we are going to be talking about the pathophysiology of a complete C7 spinal cord injury and really focus on the changes to the spine and disruptions to the nervous system. When the spinal cord undergoes traumatic injury due to falls, accidents, or crashes, it can move in abnormal ways, including bending, extending, and twisting. This can cause compression, concussions, contusions, lacerations, and stretching of specific spinal parts. Spinal cord injuries result from this initial trauma and a subsequent series of physiological and biomechanical harmful processes that result in tissue damage and degeneration, leading to a lack of oxygen and ultimately a complete C7 tetraplegia diagnosis. Physiological and biomechanical changes take place in both primary and secondary phases after the initial traumatic injury to the C7 vertebrae. The primary phase happens directly after the spinal cord has been injured and results in traumatic structural damage to the C7. The C7 vertebrae becomes severed and breaks into fragments, and it can also become dislocated. Ligaments surrounding the C7 vertebrae become bruised and tear due to mechanical forces of the injury. Mechanical trauma will damage blood vessels, axons, and cell membranes within the spinal cord C7 region. When the axon of the neuron is disrupted, electrical signals will stop being sent. The neurons and supporting glial cells, which make up the cell membrane of the spinal cord, provide nutrients in a safe environment that allow for proper function of the C7 vertebrae. Disruption of the neuron cell membrane due to structural trauma becomes broken, and all of the components inside the cell will begin to leak out. When the fluid accumulates within the spinal cord, it will begin to increase the pressure in the spinal cord, which can further exacerbate mechanical stress. Vascular damage of the spinal cord is also present as a result from mechanical trauma. The secondary phase happens only minutes to hours after the primary phase takes place. During this phase, tissue damage will continue to progress, which leads to spinal shock, systemic hypotension, ion imbalances, and an increase in calcium levels. Neutrophils and macrophages gather at the injury site, and at this time intracellular calcium levels rise, along with extracellular potassium levels, which causes cell depolarization. These changes affect the small blood vessels in the central gray matter that can lead to scattered bleeding, swollen postcapillary venules, damage to blood vessel linings, red blood cell leakage into nearby spaces, and disrupted nerve signal transmission, all resulting in cell death and scar tissue, and overall paralysis of the trunk and the legs.